Okay, well, this is Chadi Nabhan with the Hem-Onc Pulse and Blood Cancers Today on site here at the American Society of Clinical Oncology in Chicago. And I'm pleased to have Dr. Meera Mohan with me today. Dr. Mohan, just tell us where you are, where you practice, and the scope of your work before we get into some of the data that you presented at ASCO.
Thank you. It's a pleasure to be here. I'm Meera Mohan. I'm one of the myeloma faculty at the Medical College of Wisconsin, and I'm pleased to present our multi-institutional collaborative work on infection risk with bispecific antibody therapy in patients with relapsed refractory multiple myeloma.
So what got you interested looking specifically at the infectious complications with bispecifics in myeloma?
So we were very fortunate to be involved in the early studies of bispecific antibody in multiple myeloma. So we had actually noted this slightly higher risk of infections, including higher grades of infection and death secondary to infection with this class of novel therapeutics in myeloma. And we published our first experience in Blood Advances in 2020, and this led us to investigate this and take a deep dive into this important problem with this novel class of agent, which is otherwise a very highly clinically efficacious class of drugs in this disease.
And when you say infections, can you just elaborate the type of infections we're talking about? Was that in the older paper, or was that just recently in your poster discussion here?
So this is actually a larger study. So we included about 90 patients treated on various phase 1-2 studies of relapsed refractory multiple myeloma. We have also included patients who've got BCMA and non-BCMA targets. Unlike the earlier experience, we just kind of restricted ourselves to the BCMA targeting bispecific. So what we found is that compared to BCMA bispecifics, the infection risk was lower with GPRC when used as monotherapy, but when we combine GPRC with combination therapy like CD38 monoclonal antibody or immunomodulatory agent, the risk of infection goes up. So we note that the cumulative incidence of infection is much higher with BCMA directed bispecific compared to GPRC5D bispecific antibody. The risk of grade 3 and higher infections were also higher. We also had an 8% grade 5 event, all in patients treated with BCMA directed bispecific antibody.
So grade 5, that's death?
Yes.
With the BCMA directed, okay, that's obviously pretty serious, important for folks to know. But the type of infections that we are talking about, are these infections that now you can predict, where you can institute some prophylactic measures, or like what do you do now with this data? And then what, are they more viral, bacterial, fungal?
So that's a great question. So we looked into this specifically in this paper. What we found was predominantly the infections are bacterial and viral. We do note about 3 cases of PJP and 2 cases of Aspergillus, but otherwise its majority is bacterial and viral. But there was a different in the interesting spectrum of infection, whereby we had a patient with Pseudomonas bacteremia with a purulent pericarditis in the setting of hypogammaglobulinemia after being on 12 months of BCMA-directed bispecific antibody therapy. The patient actually was in MRD negative CR but developed this complication and subsequently passed away secondary to infection. And we also have rare infectious such as Rhizobium bacteremia, which we have never heard of before, Ochrobacter, which is another bacteria that we have not heard of before. We also had notably an infectious complication with norovirus, which is not what we typically see in adult patients. So this particular patient also was getting BCMA-directed bispecific antibody therapy, was hypogammaglobulinemic, had norovirus infection resulting in refractory diarrhea, which almost lasted a year, and he had to discontinue treatment.
Wow. I mean, that's unfortunate. You've got ineffective therapies and you have these things. So what are any prophylactic measures that we should do, or you would propose that treating physicians do as they start instituting these therapies?
So that's one of the important unmet need in the field. So we have so while the studies were ongoing, we really did not have a standard that we were following as far as infection monitoring and prophylaxis was concerned. But now, having learned from this, we have all of our patients on IVIG prophylaxis. So we kind of do primary IVIG prophylaxis. So patients who receive bispecific antibody, starting month 2, we put them on IVIG prophylaxis. Everybody, irrespective of IgG levels, irrespective of responses. And all of our patients, as you know already, are on shingles prophylaxis with acyclovir or valacyclovir. And we have also instituted Bactrim for PJP prophylaxis, kind of adapted to the CD4 count. We actually have put together kind of a recommendation from like an expert opinion on infection monitoring and prophylaxis strategies in collaboration with the COMET consortium, and we will have it hopefully published soon in British. I can't say that right. We'll have it available, published soon.
That's really, so it's almost patients who receive these therapies, almost like a bone marrow transplant patients, where you really have to do all of this. In addition to the BJP prophylaxis, do you need to do like fluoroquinolones like we sometimes do in transplant patients? And do you need to do like the diflucan, fluconazole, and the azoles?
So when they're neutropenic, we kind of institute neutropenic prophylaxis that will include, the antifungal prophylaxis. Along with that, we've also come up with antimicrobial prophylaxis for the first month of therapy, where we expect the neutropenia to be kind of erratic and we really don't know what. So the first month of bispecific antibody therapy, we have put our patients on antimicrobial prophylaxis, be that levofloxacin or something equivalent to that. And after month 1, we have them on IVIG, Bactrim, and update the vaccination status, get the pneumococcal vaccine in. COVID is another challenge, so we encourage our patients to get COVID vaccines, although we know clearly from the data that BCMA-directed bispecific antibody therapy have lower antibody production with COVID vaccines.
Well, congrats on this. Is excellent work. It's very important, practical, pragmatic, and really very helpful to patients. How we really balance the efficacy and toxicity. You want to deliver this effective therapy while minimizing toxicities. So congratulations and great work.
Thank you.
I'm here, Chadi Nabhan, with Dr. Mohan at the ASCO meeting in Chicago. Thank you.